Hi, Alicia.
Hi, Eddie.
Nice to see
It was good seeing you interview your patient. And thank you for this opportunity to think together about what it was like. As you think of it, Eddie, what do you take away from that encounter?
There's so many different things that so many reactions I had to it. But in general, I really remember enjoying talking to her. And I remember the conversation feeling big enough and broad enough and loose enough to kind of have led to a bit of a connection between the two of us.
That's the impression I had. The main point that I was thinking of from the beginning was how your body language or tone of voice and the way you approach the topic of screening conveyed a real sense of caring about her as an individual, her as a patient, as a person that you wanted to have a connection with. I was also impressed, let me ask you if I'm correct, by the sense of comfort and conviction that you had in describing the purpose of the A screening. And I noticed that she made a gesture, a facial expression, and a kind of dismissive gesture at the beginning, which you noticed but did not focus on directly. You did ask her to elaborate on it because you wanted to know what it was that made her skeptical. And that gave you a port of entry to explain to her that this is real, that there really are connections between what happened to her and her depression. There was a directness, Eddie, in the way you spoke with her that was impressive to me. Because very often, I think people are scared of naming depression, naming difficult experiences in childhood, naming the connection between depression or other conditions and difficult experiences in childhood for fear that the patient will feel doomed. And you were very frontal in saying, that doesn't mean that you are doomed, but that doesn't mean that there's not a connection. So you were able to convey a really complex message in a very caring manner.
I think, Alicia, I used a tactic that I tend to use with most of my patient encounters, which is to be really kind of honest and authentic, literally. Like, I am introducing the ACEs screen and I'm wondering if it can be helpful. It's not something I'm sure is gonna work with every patient. And I think being open about that, really framing it to her as something that we're just starting to do. This is something I'm really curious about and I'm wondering how she's relating to it. Describing why I'm doing it grounds me in, I don't know how to say it, an authentic experience. Like I'm actually telling her what I'm doing and thinking instead of saying a script. And so I think I was looking for a way to ground myself in that encounter. And the way I did it was telling her literally what I was doing. We are giving this screening tool out to all of our patients because we think, you know, these difficult experiences as a child are relevant to us being able to provide better care now. And I'm not saying that as a statement. I'm not saying that as a definitive statement. I'm saying that as a process statement. Like this is this was the purpose of me doing that. I'm wondering what you thought. And I think grounding the conversation in my reality instead of in a script lets me then just be open and improvise and talk about what I'm doing. And I think that was very helpful in this encounter, because I think having to recite a script, finding any way to be authentic about, so if, for instance, if a provider isn't totally facile with all of this information and all of these connections, because I've been thinking about this for a long time, I think it's probably okay to talk about that somehow. Like, this is pretty new to me too. I've been reading more about how these experiences could have an impact on our care. I'm not really sure how. Maybe you can tell me if you think they could. You know, something that can just ground, because especially when you're being filmed, but just in general, like, it's really helpful to be grounded in your comfort zone.
Your comfort zone was very apparent in this exchange. And I think that what you modeled was an integration between being open to what she had to offer and a commitment to the value of what you had to offer her. And I noticed that when she pushed back initially about the possible connection, you did not abandon your point, and you actually restated it. You restated the difficult events of childhood, and you restated the depression. You were not scared of saying the words. And I think that you relied on the power of your tone of voice and of your body language in conveying that this was a caring statement that you were making. You also said that you would only ask questions that were useful. And I think that's a very important statement to make, because you kept the focus of the conversation on the goal, which is an appropriate treatment. And I think that is what brought her around to join you from her initial skepticism. What do you think?
Well, I think it's a really good point. I mean, I'm pretty clear about what my role is in patient encounters in general. And it's mostly to figure out how I can be useful to that patient and helpful to that patient to be safe and healthy, to feel better. And maybe that sounds self-evident, but oftentimes in clinical practice, there's a big checklist of things to do, and you lose sight of that kind of that guiding force of, you know, I'm just here to help. And that sounds kind of trite, but I really am just there to help. And I don't have an agenda. I'm not trying to like impose some sort of, you know, philosophy or understanding of her depression on her. I'm really just trying to think about how I can be most helpful. And sometimes being most helpful involves showing up personally and admitting what you know and don't know and trying some things. Yeah, that's just my practice style. And I often don't get through what's on my checklist, but that because of that, but it often opens the conversation up to things that wouldn't have come up otherwise and end up being more important.
I noticed too that you countered her fear that she would be doomed, not only by stating that there is no reason for her to feel that she would be doomed, that this happens to lots of people, that it's happened to you, that is a courageous thing for a physician to share with a patient, and you share just enough to establish a common humanity. But you also made a very elegant segue into acknowledging that she was here now, that she was not doomed, that she had survived her adversities, and then asking her, what helped and who helped. And her tone of voice changed as she was thinking of her mother, school, and her creative activities. And you mirrored her pleasure in those memories and brought it from the past to the present and asked her, what is she doing now? Are her creative activities something that she's doing now? What do you think? What was your frame of mind as you were doing that link?
Well, I think it goes back to one of the things I said at the beginning, which is I try to stay grounded myself in the moment. And part of me being grounded myself is recognizing myself and my own experiences and my patients' experiences. And I have experimented with how much to reveal about my own experiences. I have my own mental health issues, my own substance use issues that I've struggled with ever since I've been a kid. And so I know a lot about what she's going through. I know about the meds, I know about treatment programs. I mean, I know all of it, you know, not all of her experience, but I know a lot more than she realizes. And so sometimes I reveal parts of my own experience because it helps ground me personally. Like, it's just helpful to, again, it helps ground me. I think the art is in not over revealing, so that it takes the conversation away from her to me. Because I'm really, you know, I've been experimenting with this for a long time, and I think there's a way of doing it that acknowledges, like I did it very vague. Like I basically said something like, I kind of been there myself. And I forget exactly the words I used, but basically I was saying, like, this isn't just you, this is me too, both in terms of experiencing trauma and to some degree experiencing mental health issues. And so part of it was to ground myself. And then part of it was to destigmatize what she was experiencing as a way, in a way of kind of by acknowledging that it's not just her, it's me and it's everybody else.
Going back to the strengths that you were able to remind her of, I noticed that you then moved from strengths to what can we do now in a very concrete and specific way. And you offered her choices. You asked her whether she wanted to continue talking with you, whether she wanted to talk a little bit with you and be connected with a therapist, and whether she just wanted to be connected with a therapist. And I think that it is a tribute to the way you had managed to destigmatize it, that she moved from the fear of being doomed to wanting to talk to a therapist. And one thing that I really liked is that even though she chose meeting with a therapist, you continue to emphasize the role that your relationship with her had in helping her get better. And you gave her a very concrete suggestion of getting dressed and going out of the house for the next visit with you, so that there could be a behavioral strategy that she could use to surmount her lethargy, her isolation, and come and connect with you. That sense that there is more than one strategy, that she can see the therapist, but there is also a here and now in the relationship with you and in the getting dressed and going out of the house, that gives her a breadth of choices, I think, that is useful.
Yeah, I tend to think that, especially if someone's depressed, that the likelihood of them doing many different things is pretty low. And so I have a number of patients who come and see me regularly, just to come and see me regularly as part of their therapy, as part of my
Yes.
with them, even though I'm an internal medicine doctor. Even though I'm an internal medicine doctor, I recognize my role in kind of structure in certain people's lives, and that I'm sometimes the only structure in certain people's lives, and it really helps for them to come in and be seen. So I have very low expectations of people. So the idea that the next intervention would be actually coming to see me sounded like probably the biggest thing. And then the other thing is I have to imagine that there's a chance that she won't go to she won't feel comfortable, she'll say she's comfortable now talking with that therapist, but something will happen in the interaction or in the messages or whatever it is that it won't happen. And so I don't want to pretend that that's, that I'm done by referring her.
And that is such an important frame of mind for a physician, that the fact that there is a partner in the team does not mean that your role is delegated to somebody else, and you use that conviction to give her anticipatory guidance about the fact that, in spite of the sense of proactive purpose that you generated in her, things might get worse. And you put it into words and said, if that happens, call me. So that you were almost inoculating her against a feeling of despair if she did not follow up with a therapist, or if she did not feel better immediately, that you were still there.
Yeah. I mean, I think I sometimes say stuff like, even if you don't do that, it's okay to come back and see me. Like, I'm not going to be pissed off at you for not going to see the therapist. I think it's a good idea to see the therapist, but if that doesn't happen, don't not come back and see me. Stuff happens, and all sorts of stuff. Like, I see that happen all the time. And so, but I think that's a risk, that if she thinks I made a referral and then she doesn't do what I recommend, that she'll feel like she's lost me too. And I didn't say that as explicitly in this encounter, but I often do, because I know how, I don't know, what's the referral acceptance rate amongst my patients, or the actually getting from that conversation to a therapy visit. It's a little easier in my clinic because we have a therapist, but even in my clinic with a therapist, more often than not, they don't actually make it to their therapy appointment.
Yes.
So
you were normalizing the defenses in mental health lingo.
Okay, good.
You were saying we all failed to follow through with our best intentions.
Yeah.
And that is just part of life.
I mean, I can't imagine practicing without somehow being at least internally self-referential. I mean, I know how hard it is for me to follow through on things. I mean, I'm guessing most people struggle with following through on things. Nutrition, exercise, all the things that I can do to attend to my mental health. So that's very present in my experience with my patients, like my own struggles and my own successes, and so I have to assume that everybody has that in them too. And for me, practicing without that awareness would be really hard.
From a didactic point of view, I think that you modeled how to implement a screening and response without so-called opening a can of worms, which is the statement that many physicians make about their fear that asking about depression, asking about adversities will lead into a never-ending conversation when there is a long line of patients waiting for them. And in the way you kept it contained and focused on solutions and on hope, you showed that one can speak about depression. One can speak about adversity, one can speak about childhood trauma, and one can do so without becoming a therapist, while maintaining your role as a primary care physician. And I think that alone is a very important message that was conveyed in this appointment with your patients. So thank you very much for that.
Yeah, thanks so much, Alicia. I do have one question. I think often in clinical encounters, when someone reveals that they're in distress, there's an instinct to soothe, to make them no longer in distress. And I also know that sometimes it's helpful to lean into those moments and acknowledge that some of those feelings are appropriate feelings and ones that I may want to learn a little bit more about, or at least allow them to air. So for instance, when the patient said that she felt doomed by those questions, I think because I had a visit to finish and a chief complaint to address, her depression, I didn't lean into that. But an interesting question could have been, to me, how come you feel doomed? What about those experiences make you feel doomed? What are you thinking about in particular? Because in truth, I kind of know what she means, but I don't really know what she means.
That is a really important question, Eddie. And I think that we can look at it from the perspective of you as a physician who has considerable freedom to decide how long to meet with a patient. And from a systems perspective, where a physician might feel that asking that question might lead into a conversation that the physician doesn't have the skills or the time to address directly. And so it is one of those times where the encounter becomes intensely personal and the choices become intensely personal. I think that the question is, would her telling you how come she feels doomed have helped you with the goal that you have for her, which is to take concrete steps to help herself? And my intuition is that you did not ask her how come she felt doomed, because you felt that that was not goal-directed enough for the purposes that you had, and that having a frontal reassurance that that does not happen, that people are not doomed in general, so that she is not doomed as an individual, was actually something that would be more useful to her in the moment.
Yeah, I think that makes sense. I think if she was expressing emotion or sadness, about some of these things, I think it may have been more important to give that space. But you're right. I think it was an idea, and it probably didn't seem necessary to address that.
One, you open up a really interesting possibility, though. She said, no, I don't think that it affects me. When you asked her, do you think that those experiences continue to affect her? She said, no, not really. I mean, I have flashbacks sometimes.
Right, and she said not consciously. So she gave a couple avenues to explore that were about either flashbacks, like you're saying, or ways she knows that intuition that she has that they're still affecting her. And I think questions probably for a therapist would would have been to explore her flashbacks, which I could have explored. But then more importantly with the therapist, like, how are these things affecting you in ways that you're describing as unconscious? And that might be right. That might be not something for most internists to follow up on, but might be really, really ripe for a therapist.
I think you are right. What I do wonder, and you are the best judge of this, is it for the role of an internist, could that be a moment for psychoeducation by saying to her, you are saying something so important that consciously you don't think it affects you. And just so to let you know that flashbacks are often ways that the mind has of telling us that we want to find meaning in things that happen to us. That those flashbacks are ways of saying, I'm still here, and I wish you would pay attention to this.
Well, now that I've heard you say that, I can definitely think that there's room for me to say that. I mean, honestly, I did not understand flashbacks in that way until you just said that. And so that's very helpful, Alicia. Like, I keep learning. So I wouldn't have had that language. But what you're saying makes so much sense to me. And it is goal directed in that it's a sign that somebody is really wanting, needing to process with somebody, and to bring these experiences out into the open, to be able to really consider them. And so I think that's really helpful language. Thank you for that. Thanks.
Thank you, Eddie. It also occurs to me that it gives her the credit
Mm-hmm.
that her mind is asking for something.
Mm-hmm. Yeah, no, that's real. I know about medications for nightmares. Like, that's literally what I was thinking when she said that. I was thinking, what medication can I give her for nightmares? But she's not having nightmares. And so I don't know if she's having nightmares. So I didn't really, that's where I went to. I went to the kind of doctor, treatment, medicine, person in me. But then I realized, nah, I don't know enough. But I didn't know enough until you said that to just validate what she was saying, and really really say, wow, what an amazing kind of insight and experience you're having, that these things really are kind of emerging, in your mind and kind of looking for a place. So, yeah.
And I think that what we're talking about is really the benevolent intent of the TRIADS model, where we highlight how these manifestations of distress really have a protective message. They are saying, we are here, we are letting you know that there is work to do to feel better. Listen to us.
Would you say I'm trying to say, okay, now I know how to say what you just said, and I'm realizing I don't. Would you just say that one more time? Like, someone tells me that they're having flashbacks, and your statement about how those flashbacks are really signs that their brain is trying to work out some of these experiences that they've had. Like, is that basically, like, how would you say it? Would you say what you
That's
said?
what you said it.
Yeah.
You said it. Flashbacks are incredibly wise strategies that the mind has to convey the message that experience is still alive in some part of the organism. It's still looking for meaning. It's still looking for attention. Don't dismiss it. Use it as a guide that can really help you come to grips with what happened to you. Find strategies that are helpful and become more whole in yourself.
Yeah, that's really helpful. I like that. It's like, you over here. So no, that's really helpful. Like, so much about medicine is creative borrowing from others. You know,
Yes.
you see someone do something, and you're like, I'm gonna kind of borrow that and use that myself. So thank you. So I think, Alicia, every clinician is going to have a different comfort level with being therapeutic or engaging patients around their emotions. Obviously, internists and primary care doctors are not, and pediatricians and family practice doctors and obstetricians are not therapists, but each of us will have our own comfort level kind of going there. And I think I realized that when I was a younger physician, it was harder for me to know what was me in the room and what was that patient in the room. You know, sometimes feelings would emerge in that interaction, or that patient would react in a certain way, and I would think it was me. You know, I think it was because I did something. And then as I've practiced, I've come to be able to understand what's them, you know, and I'm just much more facile in this emotional realm than I was when I first came out of training.
I think you are more self-assured about connecting with what the patient brings into the room. And one thing that I think connects primary care and mental health practice is that the space that the physician as healer creates between themselves and the patient is a healing space that is co-created. And that happens across the continuum of an experience with the medical profession, whether it is primary care or mental health. And, you know, a teacher can have a therapeutic effect on a student of whatever age. A nurse, the receptionist, the medical assistant in giving the tone of voice, the body language, in offering the screening. That's why we like to say that you don't need to be a therapist to be therapeutic. Therapeutic is just a fancy word for healing, for supporting, for affirming. And we can all do that regardless of our role.
Yeah, we do it in our personal lives all the time. I think
Yes.
I think it takes a while to bring that practice that actually is familiar to us into work, because somehow that hasn't been modeled. Honestly, like, it's not modeled really. You know, most of what we get taught are treatment algorithms, and not like how to be with people in a therapeutic, healing way. And so it takes some time.
Well, it's interesting when we look at it historically. The physician as healer was the archetype. And I think as science became more and more center stage, the connection between science and humanity got de-emphasized or even lost. And I think that what we're trying to do in this initiative is reconnect the link so that science and humanity are really integrated in an approach to the patient that is holistic and takes into account what is best practice at the level of science and what is best practice at the level of interpersonal connection.
Yeah, it also, yeah, I mean, not to be selfish, but it feels so much better for me as a provider to have that experience instead of being a technician or, you know, a cog in some sort of treatment algorithm. So it's a much richer experience.
What you are saying is supported by the research showing that when physicians are able to relate to their patients in a meaningful way, they have more job satisfaction, right?
Yeah, that makes a lot of sense.
Mhm.
Yeah, thanks.